Hey guys, it's Sisanie from On Air with Ryan Seacrest and iHeartRadio. Many of you may not know this, but I actually was pregnant last year with twins, and I delivered them at Providence St. Joseph's in Burbank, California. It actually is almost across the street from our studios, and it was so convenient for that reason. It's one of the reasons that I did deliver there. But that's another reason why we're here today, and I'm joined by my guest, Dr. David Lagrew. And the topic of maternity is what we really want to discuss today. But can you tell us what your exact role is at Providence?
So my technical title is Executive Medical Director for the Women's and Children's Institute. That's in the Providence system. We've set up the clinical institutes to develop our centers of excellence,
Yes.
or our important areas of care that we want to take care of. So I cover here in Southern California, which is a big job because it's LA, Orange County, and part of the high desert. So it covers about 31,000 deliveries, about 8,000 GYN procedures, and then, of course, many outpatient women's and children's visits.
Is this you're saying 31,000 pregnancies in a year?
Yes.
That's incredible.
In 1 year. So I actually looked it up one time.
Yeah, because why not?
Yeah, why not? That means we do more deliveries in a year in our region than 15 states do.
What would you say is the philosophy behind Providence St. Joseph's maternity, and what sets you guys apart from other facilities and other hospitals?
So we've thought about that very carefully. As we mentioned, we've had some good outcomes and some successes. So the question is, how do we go forward, and what do we do? So we've come up with these sort of five things. One, modern care with personal touch, right? So what that means is we're going to have the best in technology and facilities and things of that nature, but we're not going to lose the personal touch. We're not going to hurt your experience. Shared decision making. Shared decision making means we can do everything. You get to make the ultimate decision. My job is to educate you and hopefully get you to make the best decision.
Can I just say about that, it's so difficult sometimes when the decision is left to us.
Yeah.
I don't know how to describe it. I almost want you to tell me just what to do, but I know that, is it legally you guys can't, or?
Yeah, well, technically, that's
Yeah.
exactly right. That's exactly right.
Because I remember
Legally
asking,
and philosophically, no, we can't tell you what to do. On the other hand, like you say, it's funny, as my career went on, I always felt like I became almost a teacher than I did a doctor.
Oh,
right?
absolutely.
So my job is to teach you the basic understanding of what's going on with your body or your baby's conditions, so that you can make the right decision. Right.
Easier said than done,
Yeah.
but yeah.
C-section, never routine.
Yeah.
And only if you need it. And it kind of goes back to the concerns over what's the lifetime risk to you with that. VBAC when it's safe. We talked about vaginal birth after cesarean section. The reason is, again, that's a choice. There are risks of doing one or not doing a trial of labor. You should understand those, and you should make the decision. So again, doing that. And then really minimal intervention. It kind of goes back to not only just not doing too many C-sections, but not doing so many things to you that we run into the complications of doing those things. So whenever we do a test, right, there's always some false positives, which may lead us to do something to you or the baby that we don't need to do. So we don't want to miss anything, but again, we don't want to get the downside of all those types of things.
I want to add one more thing to your list, and that's that your hospital, or Providence St. Joseph's, at least in Burbank, and I'm sure it's all of them, they're really big on breastfeeding. Like, that was one of the biggest things that even attracted me to choose them as the place to deliver my twins, that it was so important to really get that connection with your baby right away.
Right.
And even like you have courses that you can come and take when you're pregnant, and even afterwards, the lactation nurses were so amazing. Like I couldn't have ever breastfed my kids without them there.
Yeah.
So I did
Well,
want to add
obviously a huge emphasis and something we really believe in.
that. Yeah.
Yep.
It's beautiful. Well, what got you into this work? I mean, because obviously you were, are you still an active doctor, would you say, or no?
No.
Yeah.
No, actually, when I took this position, because it is so big,
Yeah.
I gave up my clinical practice.
Gotcha.
And I always tell people, I miss the patients, but I don't miss the night call.
Oh, I bet.
Because my practice was in high-risk obstetrics. So
Really?
typically, when I did get called in at night, it was a big deal.
And for people who don't know what high risk, what is that for people
Yeah,
who don't know?
so in our field of obstetrics and gynecologies, there are now subspecialties. So people like myself go to these fellowships, do an extra, in my case, 2 years, the younger folks now 3 years of specific training and taking care of women with high-risk problems or babies that have things like anomalies or genetic problems, that sort of thing.
Would that put me, so like I was pregnant with twins and I was considered a high risk pregnancy, would that put me in that category then for you to be my doctor?
Yeah, it would be that because as you know, there's a higher risk of preterm birth, there's a higher risk of birth defects, there's all these different complications that can hit twins. So oftentimes in twins, we follow with the regular obstetrician gynecologist, but typically we'll get involved in many of the cases.
For sure.
Yeah.
And your background before that, you went to University of Kentucky.
I did.
And then you've been in California for 30 years at this point now, right?
Yeah, I actually came out here to do my training in high-risk obstetrics. In fact, my old director used to call me the foreign medical graduate from Kentucky because I was the only person from the South in the program for years. So
What about your family?
Family came from Kentucky.
But were they
and
in the medical field at all, or no?
Well, my sister's a pediatrician.
Okay,
And
wow.
my older sister, yeah, when I go back to Lexington, I'm known as Mary's brother. Or Dr. Lagrew's brother.
Oh, got it.
So there's that. But yeah, my grandmother was a nurse, and
Okay.
the two of us, and so yeah, we got into that.
Yeah. So how, I know that the main topic that we want to discuss today is, like, people don't realize that when you are pregnant and you deliver a baby, many times, and it's not talked about sometimes, you know, mothers will lose their lives. And this rate is actually increasing at, would you say, a rapid pace?
Yeah, you know, the history of maternal mortality is interesting because if you go back, you know, 100 years, obviously a lot of women in childbirth passed away, and it was frankly just part of life.
Right. And also the technology back then was not like...
Exactly. Once
Yeah.
we began to have things like antibiotics and blood transfusions and things of that nature, insulin, for example, then all of a sudden you began to see the maternal mortality rate just drop and drop and drop. And really, the history of it got down by after the turn of this century. We got it down in the single digits, and then it began to creep back up.
When would you say it started creeping back up?
Probably right at the turn of right around 2000. And in fact, one of the areas of interest that I got involved with was a project called the California Maternal Quality Care Collaborative. And that was started in 2006 by the state as a reaction, because by the time we came along, it had gone from 7 or 8 per 100,000 deliveries to 16 to 18. So we'd had almost a doubling, tripling.
That's
the rate.
interesting.
Yeah. And then if you followed along in the United States, it's continued to go up. There are states that have high 20s, low 30s, versus California. Once we began working on it and things of that nature, we actually have gotten it back down below 10.
Well, yeah, and that brings me to Providence St. Joseph's, because that, I feel like there was only It's very little, right?
Yeah,
Almost
yeah. I mean,
zero.
we look back, and of course, we're still waiting for statistics to come in that are a bit more recent. But in 2017, as a system, we delivered just under 75,000 births without a death. So statistically, that's a good number. And so, and it's pretty rare event in one of our institutions. Now, again, we've done a lot of work. I would credit our clinical institute system for aiding with that, but yeah, it's something we're highly focused on.
What would you say is the philosophy behind Providence St. Joseph's maternity?
You know, it's interesting because, as I said, I started about 2.5 years ago, and I would say the first thing I realized joining the organization was how highly the administration and the other folks valued women and the importance of their health care. And you know, part of it's a societal thing, right? In other words, if you don't take care of women and children,
Right.
you got a problem. But part of it is also realizing that if we do a good job of taking care of deliveries and moms and that, I remember the mom is the chief medical officer of the home. Most of the time making the decisions,
Yeah.
let's be honest. And,
Or turning it in a way to make it think like your husband's making the decision, but really you are.
Exactly.
in the
I
long
can
run.
tell you, I never went to a doctor. I wasn't allowed to. But between him and my sister ahead of me, and anyway, yeah. So it's critical that we take care of women and do a good job. And I mean, it permeates a lot of what we do. You can really tell.
It definitely sets you guys apart from, I think, other hospitals.
Yeah, I having said that, you know, part of my role, you know, outside of the system and seeing, I would definitely agree with that compared to most hospitals and most systems, we really put a lot more importance.
I got to tell you, when I was doing my tours, my hospital tours before I delivered Aza and Maxon, when I had my tour at Providence St. Joseph's, it was just like a warm feeling that I got from, I even met some of the doctors there, I met most of the nurses, and it was just a very, like, I knew right away, I'm like, this is the hospital, this is where I'm delivering these babies. Like,
Yeah,
what do you
nice.
think it is about maybe the staff at Providence that kind of gives moms, or soon-to-be moms, that reassuring feeling?
Well, again, I think a lot has to do with what we were just talking about. But part of it is you were beginning to pick up what's the mission of Providence St. Joe's as a whole. In other words, you know, if you go back and look at the legacy the sisters left us, this is the kind of stuff you get in big trouble. You know, where I work, actually, there's still some sisters on the floor.
Oh, really?
So, yeah, I got to kind of watch my language. When you're from Appalachia, it's not a good thing certain times. But anyway, yeah, I think that permeates all of our care, you know, even outside women's.
Gotcha. Yeah. Let's look at some stats. So I'm reading here that nearly 900 women die each year in the U.S. from pregnancy or childbirth-related causes, and then 65,000 pregnant women come close to losing their lives. What would you say, or what do we do with these statistics, and what do they tell us?
Well, first of all, they're too high. I mean, you know, I mean, the fact that a woman dies because she's having a child is not a good number, right? No. The 65,000, though, really what we're seeing with the maternal deaths is unfortunately the tip of the iceberg. You see so many women having to go into the intensive care unit, having to get transfused blood or have serious infections, those types of things that are hitting women, what we call the near misses. So it's a big problem. So it's definitely something that we need to continue to work on. As I said, we're doing pretty good, but A, we're not getting cocky. B, we're going to continue working on it because the real number you want is 0, right?
Of course.
I mean,
it's crazy because when I was pregnant, it never crossed my mind once that I would die. Like I was more worried about the babies the whole time. And I guess in theory, anything can go wrong, and you just don't. What are some of the, and I may sound naive by saying this, but is it because more women are choosing to have at-home births? Is that adding to this number?
Well, statistically, that's not a big number.
Okay.
So I don't think we can do it on. There are clearly social determinant changes that are happening. Women are having pregnancies later in life.
Okay.
Women, I got to be careful with this one. Women are a bit more short for their weight. In other words, the obesity epidemic has really weighed into it. And it's things like that that end up giving us increased numbers of women with blood pressure problems, diabetes, those risk factors. But having said all that, certain things that we have done, such as increasing the cesarean section rate, also play into those numbers. Because we know, and I'll stay on C-section for a minute, we know when a woman's had a cesarean section, if you look in that pregnancy, not a big difference in the outcome. But every time she has another C-section, there's this risk of very serious complications.
Really?
So I would say one of the differences in the way we look at things today is not just look at this pregnancy, but look at what's the lifetime risk to you as a woman with what's going on and what we're doing. So again, it's an important concept that we're beginning to adopt.
Why is it that sometimes when you have a cesarean, if you do choose to have another pregnancy afterwards, they usually do another cesarean? Why can't you just deliver naturally?
Most people actually can deliver. That's called vaginal birth after cesarean. And it turns out, if you look at it, probably 80, depending on which data set, 90% of people could safely undergo a trial labor, but then choose not to. And on the flip side, obviously that 10 to 20% who cannot, it really is in their best interest not to have that happen.
Gotcha. Okay, can I ask you a question that's kind of like off the grid a little bit? So I had a twin pregnancy, and I've read that if I were to get pregnant again, the probability of me having multiples again is really high. Is that a true statistic or a true fact or not?
Well, certain types, so-called fraternal twins, non-identical twins.
Yeah, that's what I had.
Do tend to run in families at a higher risk, but still statistically, your chance was about 1 in 88 that would have happened.
That's incredible.
So again, compared to Mrs. Smith, who had a singleton, now you're a little bit more likely. But now the group that obviously it's an issue for is if your twins had been from in vitro fertilization or one of the...
No, they weren't. They were natural.
That's the folks that really have the high numbers.
Oh, gotcha. All right. Well, that takes a lot.
Yeah.
So I'm like really worried about getting pregnant again. I'm like, I don't know if I can do twins again. It's a lot. So we all know some celebrities that have opened up about their pregnancies and complications that they have had. Like Serena Williams had a tough birth. Beyonce talked about having preeclampsia and things like that. How can women prevent these things from happening? Because a lot of these deaths are preventable, correct?
Some of it goes back to what we were talking about earlier in the risk factors, right? So, and again, I don't know the detail. I didn't look at their charts before coming over here.
You didn't look at Beyonce's chart?
No.
I should have faxed that to you. Nobody faxes things. I don't know why I said that.
But I think, seriously, I think those cases and really some other prominent cases, the thing that struck me was how they knew something was going wrong, and either they didn't get that across to their providers or someone wasn't listening. So I think a lot of the really preventable outcomes like we're talking about, that's a communication thing, and that's where you as patients, pregnant women, and we as providers need to work on our communication.
Yeah, I mean, I remember when I was in the last final weeks, and I really started getting monitored more around the 32nd week, I think, and I started going to Providence twice a week, getting ultrasounds. It was like every day. Do you feel anything different? Do you feel any sort of pain here? Like, just basically communicate any sort of pain at this point, because it could be preeclampsia, it could be all these different things. And so it's difficult, though, because being that it was my first pregnancy, I wouldn't say, I mean, I'm not, obviously not as educated as a doctor. And so you're getting fed all this information, and you can't retain all of it, I guess. So it's just, it's difficult to kind of like pinpoint, is this bad or is it not bad? Or is it just gas? Or is it, you know?
Well, you know, it's interesting. That's one of the advancements we're trying to do. So for example, we have a thing called Circle app.
Yes, I used it.
You used it?
Yeah.
Yeah. So at least we get the content to you where you want to get it, right?
Right,
so
you're not getting it from some random blog online
it's a trusted source. It's a trusted source, and it's not a stack of paper. You know, I mean, for years we were terrible. People would come in and we'd hand them this block of paper, and then they'd walk out and throw it in the trash and then go on their way. So we are getting the information there. But again, I think it gets into, it's one reason, you know, we're working more to get midwives and doulas and other folks that frankly have traditionally done a better job of shared decision making and you know, working more closely with women than we as physicians and traditional nursing has done.
So you would endorse somebody having a doula? You think that would be a good thing?
I
always thought that doctors maybe were against it.
You know why, where that comes from, is the fact that a lot of the times, you know, the doctor thought that, the doula thought that, they were sort of antagonistic and whatever. And so I think the programs that I've seen and we're trying to encourage with doulas get people aligned. In other words, the doulas are working with you to know, hey, this is the information we want to give out to our patients. Here's where we want to go. And frankly, I think you do have to put some boundaries of no, you know, if nursing or if the physicians think this is an acute emergency, please cede to their expertise on that. And again, it's a tricky area. You're right. It's
because I thought you guys would like butt heads or something. Like the doula would recommend one thing, and the doctor would be like, "Well, I'm the doctor. We should do it this way."
Yeah. Doctors be hard-headed? No, I haven't heard of that. No, you're absolutely right. I mean, that's sort of the, you know, it's kind of like, I'd tell you the other great example of that is the traditional birth plan, right?
Yeah.
So the joke in the doctor's dining room, it's great, she had a birth plan.
Yeah.
This is what exactly will not happen in this woman's pregnancy. Because again, you know, invariably things change.
My birth plan incorporated I had a whole playlist. I had this. I wanted this to happen, and like that did not happen at all.
So some of those, and we've actually changed it to birth preferences.
Okay.
And with the caveat that, hey, you know, we're going to try to meet your needs. We're going to try to meet the experience you want to have. But please, if something's going wrong for you or your baby or babies, understand that we may have to change things
for sure
acutely. Because one of the, you know, it's funny, one reason I went into OB is it wasn't so predictable, right? I mean, you get sort of a rush on in OB because everything's looking normal, and then boom, something happens.
For sure.
So, you know.
Well, I mean, I try to be as prepared as I was for my delivery, and ultimately we ended up having a C-section, and I was preparing myself for them to go to NICU because they were 4 weeks early, and what I did not prepare myself for was one of them going to NICU and one of them not going to NICU.
Yeah, there you go.
And so I was just like that total, I mean, all I knew is I delivered the babies, I was holding Asa, and then they brought Maxon over to me, and then they're like, we have to take Maxon to the NICU, and it just never dawned on me that was going to happen.
Yeah.
And that was a crazy 48 hours because...
You know, it's funny you should say that because in the day I delivered a lot of triplets because, you know, we were in the height of the
risk.
Triplet and quadruplets and even more. And boy, as you say, you know, about 1 in 3 or so, the triplets would go home with the mother. And she was like, oh my gosh, I wouldn't, well, what do you mean? I haven't got the nursery.
I stayed for
And
4 days
so,
at the hospital, and I'm like,
again,
I need more days.
Yeah, I mean, I think sometimes, and again, I put this back on us a little bit. We didn't prepare people that, we're going to tell you, bad things could happen, so you'll do the right thing, right? But, by the way, that's, sometimes things go right too.
Yeah, I know. I consider mine, still going right. He had a
Yeah,
little fluid in his
yeah.
lungs, but
Yeah,
everyone in the
sure.
NICU was fantastic. They almost joked with me that like he was a piece of cake compared to all the other babies, because it's like you actually had babies that were in there that were like 2 pounds.
Yeah.
So.
Oh no, they love babies like your own.
Yeah, they were. I guess I remember he was like burping him, and I was
Yeah.
like, "Isn't that kind of
Yeah.
hard, rough?" And they're like,
Oh,
"No,
yeah,
this is
right.
how you do it."
Exactly.
I'm like, "Oh my God, I'm learning so much."
Yeah.
If we could take away, if you can get, I know this is a lot of information that we're talking about right now, and I'm hoping that expectant moms are watching, and moms to be are maybe watching. What's some bit of information that you want to get out to all these mothers and parents?
Yeah. So I would say my best advice for people is for them to be an advocate, to learn not only what's happening to them, but why. In other words, sort of demand that from her caregivers, that she understands what's going on. I think work as a team. Medicine is now team-based, and the best outcomes come from that and such. And then I think the last thing, I always use this line with my patients, is the only time I'll get mad is when you don't call. I think too often, it's 4 in the morning and I don't want to bother him or her, that sort of thing. Actually, yeah, you do.
Yeah.
And again, I think it's one thing we as caregivers are learning, that listening to mothers and things of that nature is an important part of the solution.
Gotcha.
So we've got to over-communicate. It gets back to our communicate discussion.
It's funny you bring that up, because I have a hard time asking for help, and just in life, in my day-to-day life with work, at home sometimes, even with like the babies. I like to pretend like I can just handle everything. When I was pregnant with them, I would experience random things. I know that one night I got really dehydrated. Now I know that it was dehydration, but at the time I didn't know. And I woke up with like the most extreme pain at like 2 in the morning. I don't know at the time, but it felt like just the worst cramps of my life. And it turned out that I was dehydrated, and that was my
It's the
uterus.
simple stuff, right?
And it was just like I didn't drink enough water that day, but I felt terrible about calling my doctor. I think at 2 or 3 in the morning, and she was just like, "Please don't. Like, this is why I'm here for you." And you kind of just don't realize it when you're in it, that you guys are here for us.
Yeah, that's exactly.
Well, thank you so much. This was an honor actually to speak with you. It really was.
wow.
I mean, I usually
Same back.
interview musicians and things like that. So this is a good, like, in-depth interview about real life and experiences that us women go through, and parents in general go through. So I thank you again for taking the time out of your busy schedule to speak to us. Dr. David Lagrew, everybody, thank you very much. And if you want to get any more information about anything that we talked about, we're going to put a direct link below this video so that you can check it out.